Good evening, everyone, and welcome to this webinar on points of care ultrasound and getting to the point. So for those who don't know about PhysEquip, we focus on MSK rehabilitation through medical technology and education. So tonight we are delighted to be joined by Jonathan Hobbs, who will be delivering a short presentation followed by a Q&A. So we do have a couple of pre-submitted questions to get through, but if you are watching it live, please put some questions into the Q&A section and we can get round to addressing those too. So on that note, I'm going to hand over to John for his presentation.
Thanks, Katie. Thanks everyone for taking some time out to engage with this. Appreciate it. Appreciate your time. So I'll tell you a little bit about myself and what we're going to be talking about. It's going to be a fairly short presentation. I'll tell you what it is and what it isn't. And I'll tell you a little bit about myself and where I'm coming from. So those of you who know me know I've been a physio for the last 25 years, practiced clinically all that time, worked in the NHS, private sector, professional sport. I'm known these days for teaching acupuncture and dry needling. I'm the chair of the AACP as well. But obviously my background's exercise and it's always been the mainstay of what I do. But over the years, I've added more and more needling into that. Well, for the last 20 years, really, 20 plus, I've added it in. I teach a lot of different areas. I teach in the UK, I teach in the US, in the Middle East, in India, and so on as well. And I talk about how we use needling to expedite outcomes, to improve loading and exercise and so on. So it's always about exercise, but it's how do we use needling to move on through that. And so in the last few years, I've been engaging more with ultrasound as well, diagnostic ultrasound. So I'm going to talk to you a little bit about how I combine those two. And that's what this presentation is going to be about. What it's not about is what is ultrasound generally, you know, from an MSK perspective. There's already a great presentation on that by Dr. Dan Brook, which is on the PhysEquip Academy. So I'll direct you to that. There's no point in me reinventing the wheel. He's already done a fantastic job with that. So I'll direct you to that. It's also, even though we're talking about needling, it's also not an injection presentation. Again, I can direct you to a fantastic presentation by Chris Myers. Again, that's on the Academy. So I don't want to duplicate that work because those guys have both done that better than I would anyway. So what I'm going to talk about is how it relates to acupuncture and dry needling. And I want to talk about the diagnostic needle. So it's point of care ultrasound. I'm getting to the points. And it's the needle as a diagnostic tool as well as diagnostic ultrasound, and how these kind of things fit together in this bit of a Venn diagram of diagnosis and treatment and assessment and so on. So how it all kind of fits together. Excuse me. So what we're going to be talking about is the importance of understanding the three-dimensional anatomy, because that's really played out when you're needling, particularly at depth. Some people ask me, like, well, how do you get advanced in needling? And they want some fancy technique, and there's no real, there's no real sort of idea that's going to make you any more advanced. The things that make you more advanced in clinical practice is knowledge of anatomy and physiology, particularly when you perform an invasive procedure. It's understanding where you are and why you're where you are as well. So we'll talk about that in a moment, but it's understanding that three-dimensional anatomy. And what ultrasound does, which is great, is it gives you the anatomy and it allows you to see the physiology as well if it's there, if it's pathological, which is going to help with your diagnosis for musculoskeletal conditions. And so we'll talk about where the ultrasound fits in with the needle and vice versa, and how you can use them together and how you can use them separately. So if you haven't got an ultrasound, I'm going to give you some ideas about that as well, and why ultrasound might be useful for you, and a little bit about how you can learn about applying it as well. So things we're going to touch on is enhancing clinical diagnosis. And that's really just going to help you problem solving. Things I talk about when I'm teaching all the time is the idea of solving N=1 problems, like individual problems. We can look at a lot of big scale studies, but when we get in clinic on a Monday morning, something else I talk about in courses is what are the Monday morning techniques? What's your takeaway? What are you going to do Monday morning that's going to help you solve an N=1 problem? So problem solving, yeah, it's a really useful thing to consider when we're thinking about diagnostic ultrasound. It's going to help inform us. We're going to think about the pathophysiology. And of course, that's diagnostic, but then we're moving straight to treatment. So if we're using a modality like needling, what's the mechanism of the needle and how does that relate to the pathophysiology of the presentation? We want to get out of this idea of just prescriptions. like it's shoulder pain, so I needle this, or it's hip pain, so I needle that. We've got to move a little bit further away than that and start to think a bit more specifically. And I'm going to talk a little bit about that. Also, the layers of tissue and target specificity. So how specific do we need to be? Well, for me as a clinician and an educator in needling, the specificity of needling depends on the pathophysiology of the problem and what you're trying to change. And that's where ultrasound's great, because it can show you if there's pathology present and where you need to be and what you need to be doing about that to some degree. I'm also going to touch on the concepts of loading and loaded tissue. And I'll define what I mean by that as we get on. And we'll talk about the diagnostic needle as well. So how can you use a needle to tell you something? What's it going to tell you? And how's it going to tell you that? And what does that mean? One of the things I'll say, as I always say, whenever I'm teaching, for those of you who know me, is I'll put forward a quote that's attributed to Aristotle, because you guys have all got your own experience, you've all got your own opinions, and you've all got your own ideas, and that's great. And I'm not here to, challenge those ideas. I'm here to challenge thought, but not necessarily your ideas. So this quote by Aristotle that I always mention is the mark of an educated mind is the ability to entertain an idea without accepting it. So all I'm going to ask you to do is to entertain the idea. You don't need to accept it. So for me, clinically, the ideas that I come up with regarding needle diagnosis have borne me fruit for the last sort of 20 years. So I'll share those ideas with you and how that relates to the ultrasound. If you don't like it, you don't want to buy into it, that's completely fine. But just entertain the idea. You don't need to accept it. So where does point of care ultrasound, as we refer to it diagnostically, sit within physio? Well, it's grown in its popularity and it's grown in its prevalence over the last sort of decade or so. And it is considered to be in scope of practice. It's in that third pillar of therapeutic and diagnostic technologies. And it's great because, if you check out the presentation by Dan Brook, which I would recommend if you're new to ultrasound. If you're not new to it, I'll check it out anyway as well. He's got some good things to say. It's got a variety of applications, very much for us in physio, in the MSK field. Of course, we do see it in other areas as well. It's becoming more popular in pelvic health as well. And we will see it in some other areas as well. But really the mainstay for most clinicians, I think, is probably the MSK field, where we'll see it in rheumatology, orthopedics, sports medicine in particular, particularly when we're looking for those really quick diagnoses, like there and then, when we're quite hot on the problem and we want to see what's going on in the acute phase, make some decisions about further imaging or further treatments or evaluation as well. It's relatively accessible now as well. If you look at the cost of the hardware and the software now compared to what it was and what you're getting for that value and that quality and that imaging, it's getting better every year, and we're seeing that improving all the time. So it's great for real-time capabilities for those situations in clinic, making decisions and so on. So that pathoanatomical diagnosis. And I suppose what we need to understand from that is your diagnosis is going to be based on what you can see. And this can relate to the equipment that you're using and how good you are at utilizing that equipment as well. There are other factors, but those are two of the large sort of variables that come into play there. But we can use it to make decisions about diagnosis and subsequent treatment. It's useful for examining the three-dimensional anatomy. So looking at the sublayers. One of the things I talk about when I'm talking about needling, and I also teach a lot of anatomy and cadaveric anatomy, is the three-dimensional nature of anatomy, which you don't really see in textbooks. And even apps that render the image in 3D are actually obviously in 2D. So you really don't get that. What ultrasound gives you is that three-dimensional aspect. And so that's so useful to understand the interrelationship between tissues as well. And when we're needling and we're looking to hit a target but miss other structures, it's incredibly useful to understand where that is, and how we can identify those structures and those targets. So if we look at some of the guidance that came out from the CSP last year, they talked about it from practice guidance for physios using point of care ultrasound. And they said that you must ensure that it supports your physiotherapy practice and it informs your management. And I think that's where it's really got a value. You know, you can use it in clinic. I was going to say quite easily. Well, it's not easy to learn how to use it, but once you have those skills, the application of it is pretty quick, pretty easy, and you can make some really good decisions. And I feel that it does inform your decision making significantly better than just the assessments that you have in clinic. But it adds to it. It doesn't replace any of your clinical assessment. It just enhances it. So again, if we look at the paper that CSP put out, another one on context, talking about how that fits in with practice, and we look at the education, training, and competency, because this is something that's excuse me, this is something that's very very close to my heart, really, as someone who educates in anatomy and physiology and so on. I'll say to anybody that, you know, I've taught upwards of 2,000 physios over the years from postgraduate perspective, and then many more undergraduate as well. Your anatomy can never be too good. You can never know too many things. And what ultrasound allows you to do is really enhance that knowledge. But to get that, you've got to put the time in with it, you know. So it's accepted to be in scope of practice. It's a post-registration thing, but where do we get that education? Well, what you really need is to understand what are the core requirements of training to be able to understand and utilize it. So you need to understand certain things that CSP have outlined here. Although the training pathways can be variable, there's certain things that you really want to focus in on. And any training program you do undertake should meet these requirements, and it should be very clear from the outset what your goals and your outcomes are going to be. So you've got to think about the technical considerations of the of the devices. Unfortunately, for some people, not going to like this, you're going to need to know a little bit about physics. It's actually two of the things that I say physio should really embed themselves in, particularly MSK, is physics and physiology anyway, because physics is how something moves and physiology is why it moves. And you're going to need both of these things with ultrasound anyway, but you're going to need the physics of the ultrasound and how that relates to the physiology of the structures. And that's going to give you the interpretation of image and so on. So you're going to need to know how to optimize image as well. And management of what's referred to as artifacts. And these can be nuances in the image that create, well, how can I put it? They will alter the way that you see the image. And if you're not familiar with them, you can misinterpret what you're seeing. And so it's understanding how the physics and the physiology interact with that. So you're going to need to know all those things. And when it actually comes down to the scanning, you're going to need not only to scan, but you're going to need to be observed doing that, because you need someone to tell you that you're doing the right thing. It's not enough that you spend the time with a scanner and try and interpret it yourself. You know, that's going to take you a very, very long time. And you're not going to be sure where you're at with that. So having suitably experienced clinicians who have been through that, been down that road, who have got the clinical mileage, and they're qualified to educate and mentor you. And you've also got to be scanning the group that you're going to be interacting with clinically. It's very important as well, because obviously it's pathology specific as to what you're seeing and how you're seeing it. So for me, my pathway was via a sports medicine ultrasound group, SMOG. I've put a couple of links on the bottom of the page there for them. I highly recommend those guys. I started out with like a introduction to the foundation course, and then I went on to do a full mentorship program with them. And we had to run through hundreds and hundreds of scans, it's hard work, but it's very rewarding, and it gives you the confidence to be able to make decisions, you know, and that's what you need. You need confidence and competence to make good clinical decisions. And the guys there, huge amount of knowledge that they're very happy to share. One of the things I always say to my students is that if you're the smartest person in the room, you're in the wrong room. And I knew within about 5 minutes of walking in the room with the guys from SMUG that I was definitely in the right room. I definitely wasn't the smartest person in that room by a long way, which is where you need to be when you're learning something. You've got to put your ego to one side and realize you're going to be rubbish at it. And you need to embrace the fact that you're not very good at it. And then you need to just go with that. And once you put that ego to one side, And for someone who's been doing something for 25 years, putting your ego to one side sometimes a little bit difficult, but you need to put that to one side and you need to just get in with it and go for it. So training, I think, is probably the single most important thing when you're going into this, and it's set out what you see as your training sort of program, your protocol. You've got to make the time for it. You've got to do the scans. You're not going to buy a machine and be good. You've got to buy a good machine and do a lot of training. And then I remember I bought a machine and I didn't think it was great. And then about 12 months afterwards, I was using the same machine. I thought, actually, this machine's pretty good. And it wasn't the machine that changed. I just got better at finding images. So that's something to consider. So put a couple of links on there. Check out their YouTube page. Lots and lots of videos on there. Couldn't be more helpful. And actually, the images that I've used here are by kind permission of SMUG. So that's my advert over. But couldn't recommend them enough. They don't pay me for that ad, by the way. It's just that I think they're that worthwhile checking out. So how do I use it in my clinic? Because that's really what I want to talk about now. So I'm going to use it for a pathoanatomical diagnosis. And of course, not every problem is pathoanatomical. We know that, you know, once it's become maybe nocioplastic, it becomes a different sort of problem. But of course, a lot of problems start being pathoanatomical and can give us some indication. If we're going to needle as well, not necessarily that we are, but it's something that I do a lot of from a treatment and a diagnostic perspective. And diagnostic needling can tell me whether I actually need to needle or not, ironically, you know, going forward. So I'm not wasting time with modalities. But I use it for a pathoanatomical diagnosis. And so it enhances my clinical diagnosis. If I can get as much information as possible to start with, then I can make good decisions about what the pathway is for that individual. And, you know, having worked in sport in the past, and I teach for a number of premiership clubs, and I've taught with England and with EIS and so on. You know, decision making is very important. You need to be optimized to be able to make good decisions, be able to act on that with your rehabilitation. How much loading can we do here? Because everything's about loading, everything's about exercise, everything's about function. So you can make some good decisions with that. I'm also looking at, when I'm thinking about treatment from that, is how does the pathophysiology of the problem match the how does it match the mechanism, the modality? You know, how do these things fit together? You know, where do we go with that? So understanding what your modality is doing and how that relates to the pathophysiology is very useful. So I'm going to talk about that in a moment. And the modality I'm going to be talking about, obviously, given my practice and my background for teaching, is needling. Now, again, one of the problems that people ask when it comes to needling is, oh, how do we treat this? And really, that's not the question you should be asking. The question you should be asking is why are we doing this? You know, and if you understand the why, the how presents itself to you. But the why comes from understanding the pathophysiology and the mechanisms. So how that all fits together. So what I'm going to talk about is the mechanisms. I'm going to talk about 5 reasons to needle. But before we get into that, we need to think about being safe and effective. So gave you just a sneak peek of that a moment ago, that slide. So we're going to look at safety and effectiveness. So I like to talk about this idea, this triumvirate of respect, which is if you respect the patient, respect the anatomy, respect the technique in that order, you're not going to have a problem. I'm expert witness in legal cases where needling hasn't gone as well as clinician would hope. And so I give evidence in court and I write reports and so on. And there's a large percentage of adverse events that could have been avoided. You know, when we look at pneumothoraces, you know, we could argue that they could all be avoided if people had a better understanding of anatomy. And that's one of the great things that ultrasound can do for you. It can show you where those structures are, not guess where those structures are, or I think it's here, or I think it's there. It can physically show you. And I've used ultrasound from a teaching perspective to, you know, to explain to students, bear in mind all my students for needling a postgrad, they're all qualified physios or doctors or nurses, explain to them exactly where the lungs and the pleura are, not roughly here, but exactly how many mil they are from a certain area and how you would access that and how you would not access it as well. So that's really helpful from my perspective. and also for the for trainees' perspectives. So if we think about that triumvirate for a second, you think about a triangle, respect the patient, the anatomy, technique. People fixate on technique, whether it's manual therapy, whether it's needling, whether it's exercise, and you shouldn't fixate on technique. You should fixate on anatomy, because technique is 100% dictated by anatomy. That's why it is what it is, because of the anatomy, and it has to work with that. So if you're going to respect the anatomy, well, subsequently, you need to come back and respect the patient. If you lose track of any one of those three, you're going to find yourself in trouble. And that's what I see with adverse events and what I see with legal cases. And so if you lose respect for any of those three components, you subsequently lose respect for yourself, because you'll find yourself in a position you don't want to be in. So understanding the three-dimensional anatomy is great. And the ultrasound is great for that as well as a diagnostic tool. But it can also be useful for not only finding the structure and diagnosing the problem, but directing the needle. So if you want to hit a certain structure, or you want to be adjacent to a certain structure, which is also very important, we'll talk a little bit in a moment about perineural needling, needling for different physiological effects. So for things like if we were needling for overactive bladder, which is percutaneous tibial nerve stimulation, if we're utilizing that, then it's useful to lay the needle next to certain neural structures, so we can get a myotomal to a visceral tomal response. And so finding that structure and going adjacent to it but not hitting it is a really useful thing, particularly for the patient. They don't really want that. So again, how do I use it in my clinic? Pathoanatomical, enhancing diagnosis, targeting tissue as well. So finding what I want, being where I need to be. If we're stimulating for, if we're needling for pelvic floor pain, and you might be needling pudendal nerve, knowing where that is can be useful. Ultrasound can help you with that. It can help you with sciatic nerve. It can help you with posterior tibial nerve. It can help you with common peroneal nerve. It could be useful for all these peripheral nerve stimulations. And so it can help us be safe and effective. I'll just draw your attention for a moment to those two articles that I wrote in the last couple of years, which related to legal cases that I worked on. The cases aren't discussed in the papers, but the research that I did to inform the court documents taught me some things that I wasn't necessarily aware of, or it changed my mind. One of them changed my mind about some of the things that I perceived for a number of years, and I felt that it was a good idea to share that with everybody, because if it changed my mind, it could change your mind about things. So check out those papers. If anybody wants those, reach out and I can send those on to you. So just want to talk about reasons to needle, because it's an important thing to understand. A lot of people have different perspective on acupuncture dry needling. I'm going to break it down for you really, really simply. Okay, like Einstein says, if you can't explain it simply enough, it means you don't understand it well enough. So let's see how simple we can make this. There's 5 reasons to needle from an MSK perspective. Okay, the first one is local healing. Put the needle in, you can get release of CGRP. If you repeatedly needle, not only we get vasodilation, you get angiogenesis. You can use it for healing. That's the trauma response that you get from needling. It's not a placebo thing. You don't need to believe in it. It starts a healing process, whether you believe in it or not. You don't have to believe in needling, for it to work. The second one is the local opioid effect and the adenosine response. Adenosine will be released, bind to C fibers, inhibit pain transmission, and you get a local opioid response as well. So you get local analgesia off the back of the needle. The third one is a myofascial effect, and this is where the diagnostic needle comes in on reason 3. Some people think of it as trigger point needling. Trigger point falls into what I would refer to as reason 3, but it's not dominates. It doesn't dominate reason 3. Any myofascial needling could be reason 3. So you're needling the target there. Reason 4, segmental. So segmental analgesia, and this will be perineural. Doesn't have to be analgesic though. So if we're treating overactive bladder, and we're needling for PTNS, percutaneous tibial nerve stimulation, then we're utilizing reason 4, segmental perineural needling. And then reason 5 is the central systemic, central descending, homeostatic, autonomic, central opioid, ACTH, autoimmune, anti-inflammatory responses. And for this, we want to be peripheral and perineural, most probably. So we've got 5 reasons to needle. We've also got 5 layers of target tissue. you know, skin, adipose tissue, connective tissue, muscle, bone. Where do you want your needle to be? In most cases, for acupuncture dry needling, you probably want it in layer 4. And that's where we can use it diagnostically as well. So when we're thinking about pathophysiology versus mechanisms, and we're thinking about the anatomical considerations, we're thinking about the target and the collateral risk. So if we want to hit a certain structure, well, you know, what do we need to be doing? Where do we need to be? So if we're thinking about the 5 reasons to needle, if we're needling for reason 1, we need to be next to the structure, because the inflammatory spread around the needle is about 25 mil. So if we're any further than that, then we're not going to get it. The second reason is the local analgesic response, you know, and that is going to be close to the target as well. The third one, the myofascial response, we need to be in the muscle, preferably the muscle belly of the target that we want to be hitting. And if we're in the muscle belly, we're near the motor point. If we're near the motor point, then we're near the innervation. So we're fairly perineural with that one. Reason 4, we need to be in a segment, that's the dermatome or myotome, that relates to the same segment innervating the problem, so the same spinal nerve relationship. And we need to be perineural, which is next to the nerve. Quickest, easiest way to be perineural is to be at the hands, so the wrists and ankles, knees and elbows, hands and feet. The reason for this is you've got a major nerve trunk, it's tracking out the nerve roots, it's heading down the limb. When it gets to a bone, like the knee, or it's getting to the elbow, it's got to get superficial. Can't go through the joint, so it's got to come to the surface. So for a short space, a short period, a short area, it's exposed superficially. And then it goes deep again, and gets to the wrists and ankles, becomes superficial again. So we can be peripheral and perineural, segmental and perineural in those sort of settings, and then peripheral and perineural as well, which is like reason 5. So the reason you're needling will dictate the target that you want, and also how close you need to that target. So this idea that, oh, you can stick a needle anywhere, that works for some pathologies. It works for migraines, of course, and it works for back pain from a central descending effect. But I don't want to treat back pain from a central effect. I want to treat it from a mechanical effect, because I want to load it. I want someone to exercise. So I might use the needle diagnostically for something like back pain, whereas I wouldn't use the ultrasound for that, because it's not really going to tell us too much about the problem, but the needle can, you know. So the specificity of the technique relates to the pathoanatomical diagnosis of the target and proposed mechanism that you want to use. If that's all a bit quick and complex, because I realize I've got a limited amount of time, then I talk about this a lot on my courses, on my needling courses, particularly the more advanced ones. I teach a course on tendinopathies, radiculopathies, and chronic recurring problems, which is a more advanced needling course, where we really get into this idea of needle diagnosis, particularly in the lumbar and cervical regions. So just going to run over some clinical applications with that that I would use in my clinic. So looking at soft tissue trauma, ultrasound diagnosis with a needle intervention. So the ultrasound is going to identify the traumatized tissue, could be strains, sprains, contusions, and so on. And then we'll look at the concept of how I might address this. So the concept behind it would be, if I want to go local to the tissue, let's say I've seen a tear and I want to go local to that. So I want to stimulate healing. So we can put the needles next to that tissue. It's going to stimulate healing. So we need to be close to it to get that reason 1, that local physiological healing response. Off the back of that, we're going to get reason 2, which is analgesic anyway. You may also want to consider the potential of the loading tissue. So the loading tissue will be the muscular contractile tissue around the area of trauma. The loaded tissue is the trauma site. That's the one being loaded upon by the active structures. So we can think about needling that as well if we want to. What targets we need to be in? We'll layer 3 for connective tissue, depending on where the damage is, layer 4 for muscle and tendon, layer 5 of going down to ligaments and so on. Intervention wise, well, reason 3 is myofascial. So if I was actually going to needle that, say it's in the quads, I'd be needling the trigger points or the myofascial tightness in the quads, either side of the injured area, and I would needle around the injured area, and the ultrasound would show me where the injury is and where I was going to needle there. For the trigger point loading, I wouldn't need to see that on the ultrasound, because you're not going to see it, but you would see the trauma, the pathoanatomical relationship. So that's how I might use it for something like that. If I was going to use it with, say, something like a tendinopathy, here's how I would talk about loading and loaded tissue. There's an assumption, obviously, that let's say you've got a lateral epicondylar pain, that that is tendinopathic, or it's pathoanatomical in some respects. But you could scan it and it not be pathoanatomical. It could just be generating pain from loading of the extensors to the attachment. It could be ECRB, something like that. It could be overactive, could be starting with a neck problem. It could be just overactivity in the extensors. So we could needle the loading tissue from a myofascial perspective. So that'd be like a reason 3 perspective, would be needling that. And the loaded tissue is the connective tissue at the extensor attachment. So if we scan that and it was pathoanatomical, I would needle that directly as well. So I'd be needling the attachment for reason 1, and I would be needling the muscle for reason 3. And that's how I put together that diagnosis. If, however, I'd scanned it and there was no pathology, there's no point in sticking the needle at the attachment, because that's not the pain generator. Pain generator is the loading tissue, and then you want to unload that. So you may want to needle myofascially for that. So it's going to help you identify the relationship of what intervention you're going to use. The needle diagnostically would tell me where the tightness is in the muscle, because if the muscle is loaded, and by loaded, I don't mean like actively loading. I mean, it's like it's loaded at rest as well, because it's myofascially tight, and trigger points or any other dysfunction there, then needling it will tell you that, because the tissue will be contracted, so it'll have an increased cross-sectional diameter, which means it'll be more dense, and you'll feel the difference in the needle. When the needle comes out, it should be more loose, and the range of movement will go up. So if we were going to do that kind of diagnosis in clinic without the ultrasound, and we were looking at something like a movement dysfunction, and typically you could do this with the back, and this is why needling can be useful, because it takes something like non-specific lower back pain, and it makes it a little bit more specific, because the needle is structurally specific. So you could use the ultrasound to identify the muscular structure that you wanted to hit, to make sure that you knew which one it was. It's not necessarily going to diagnose anything pathoanatomical if you've got non-specific lower back pain. And of course, it's not really a great tool for that sort of thing. It's much more useful to direct the needle in that instance, rather than diagnose the problem. The needle diagnoses the problem, because when you hit the area that's tight, dysfunctional and so on, then you'll get a replication of those symptoms, the patient. And then when you're using that diagnostically, you can use that then as treatment as well. All the ultrasound's going to do in that setting is tell you where you are. That's what that is. But if you haven't got that, then you can still find the areas that's dysfunctional. So you would be needling from a loading perspective, so a reason 3 perspective, into the myofascial structures, whether that was something like longissimus or iliocostalis or multifidus. And it's understanding the 3-dimensional relationship of those muscles, or spinalis and so on, and how they fit together. And as I said before, there'll be an increased density on those when needling. And if you're successful and you're in the right place and do the right thing, there'll be a decrease in the density and an increased range of movement afterwards. There may also be dysfunction at loaded structures, which are not pathological, so it might be useful to look at those as well. But of course, we'll be in layer 4, which is the muscle, and our reason is reason 3. Those 5 reasons to needle is a paradigm that I teach quite a lot. You won't really find those in textbooks. I have got a book coming out, there's a pitch. But it's something that I talk about in my paradigm for clinical reasoning with needling. It's 5 reasons to needle, 5 layers of tissue. Like, where do you want to be? What do you want to do? And that's where the ultrasound becomes useful. Realize I've not got much time to talk about this. So that was a quick overview of how I might do that. If anyone's interested anymore, you can reach out to me. You can find me on social media. I've got LinkedIn under my name there. You can find me on Hobbs Acupuncture, where I'm talking about some concepts. So you can find that on YouTube, and just check out those videos, talk a little bit about anatomy and palpation as well. Or you can go on Instagram and you can contact me on any of those and ask me any questions, and I'll do my best to answer those to you. Or you can come along on a course and ask me in person, and I'll show you as well how it all works. I've been a clinician in clinic for the last 25 years, so I'm not just about the teaching, so I can show you how that works in the real world. So things that it can be useful for, as I've said before, if we summarize this: enhancing the clinical diagnosis to help with problem solving, help you to understand the relationship between pathophysiology and mechanism and modality. So, is there something pathoanatomical? Would needling be beneficial for that? Is it loading? Is it loaded? Is there anything? Is there not? identifying the layers of the tissue and target specificity to be safe and effective. You want to find your target to be effective, but safety is of paramount importance when you perform an invasive procedure. Combining the needle to enhance musculoskeletal diagnosis. And ironically, I do needle almost everybody, but not necessarily for treatments, for diagnosis, particularly for lower back pain. Because what I want to do is I want to affect a change for loading to get them exercising as quick as possible. For reason 3 and the diagnostic approaches I'm using here, it's to increase rehabilitation and shorten my return to loading and exercise time. And that's why I'm using it. So it can be useful to evaluate the loading and the loaded tissue presentation, both from a needle and an ultrasound perspective. So that's a little view on the ultrasound and how I'd use the needle and how that all combines together. Probably a little bit different from some of the other stuff you've heard on ultrasound before, but that's kind of how I use it. I'm going to be using the ultrasound more in teaching as well. I teach a lot of anatomy, a lot of cadaveric stuff. There's some events coming up. Again, you can reach out to me about those. A lot of cadaveric events we've got, unique opportunities there to really get into the anatomy and see where this all fits together. And that really enhances your ultrasound knowledge as well, because you can see the structures, you can come back and look at it on the scanner, see how it all fits together. And it makes much more sense with your clinical diagnosis than in your problem solving. So I'm going to hand you back to Katie now. That was as quick as I could do it. I realised it wasn't that quick.
It was great. Thank you, John. No, good timing, good timing. So just on the courses there that you had up, we've just had a message from Nikki from PhysioTrack. Do you have any upcoming courses in Manchester?
Yeah, so what am I doing? I'm doing a course. What does she want the course on? Because I've got quite a few things. So I've got a course coming up on clinical anatomy and palpation, which is just a really, really quick hints, tips and hacks on how to find everything in the body. I find that, you know, even experienced clinicians, you know, when you move away from, you know, anatomy education and you're working in clinical time, sometimes you can drift away from some of the specifics. And again, when you're less experienced, particularly guys from the last few years coming out with everything that's going on with COVID. So we've developed this one-day course. It's in Rochdale, which is why I mentioned it, near Manchester. And it's just quick hints, tips and hacks on how to find everything in the body. I'm teaching it. I teach it for EIS, Institute of Sport. Taught it for a lot of different other organisations as well. That's at Bradley Physio in Rochdale, and that will be on the 12th of March. That's a Sunday.
Excellent. Lovely. All right then. So as I said before, we do have a couple of pre-submitted questions to get through. So we'll just go through a few of those. And if you haven't done so already, please do submit some questions onto the Q&A section and we can get to those as well. So, John, the first question I have is, please can you clarify the difference between the terms acupuncture, dry needling, and we've got dynamic integrated needling as well?
Yeah, right. So start from the beginning. Just imagine a big circle, okay? If you draw a really big circle and I put TCA in that, that's traditional Chinese acupuncture. Basically, that is, you can needle anywhere in the body to treat anything, literally anything. Okay, so that's traditional Chinese acupuncture. Then you've got Western medical acupuncture. So that's what I teach, is Western medical acupuncture. So Western medical acupuncture is reverse engineered Chinese acupuncture. If I was going to draw a circle, it would be slightly smaller than the one I've just drawn. So WMA in it, Western medical acupuncture. And you can stick needles anywhere to treat anything, providing you have the physiological evidence to do it. So it's an evidence-based approach, reverse engineering acupuncture for a medicalized practice. So we're looking at pathophysiology versus mechanisms. And it will encompass those 5 reasons that I've talked about. Reason 1, local healing. Reason 2, local analgesia. Reason 3, myofascial. Reason 4, segmental. Reason 5, central. Dry needling is local acupuncture. So you just needle where the problem is. That's it. There's no peripheral segmental. There is no, peripheral central. descending, there's just your needle where the problem is. So that circle is a little bit, well, it's actually significantly smaller because you take away all your peripheral effects and you just go muscular and you go right next to the problem and get dry needling. And then you've got trigger point needling. Some people say trigger point dry needling. I know I do that on some of my courses, but trigger point needling then is a technique. And that is just needling the trigger point in the muscle. So that is an element of reason 3. So dry needling is reason 3, pretty much. And trigger point needling is a facet of reason 3. So it gets smaller and smaller and smaller. So I teach all those 5. So I'm teaching everything. So dynamic integrated needling. Okay. That essentially is all forms of needling, and it doesn't limit itself to dry needling, trigger point needling, and so on. It's a physiologically based approach to problem solving. So we take all the potential mechanisms that needling can have relative to the anatomical locations. Yes, we utilize acupuncture points in a lot of areas. The reason for this is if we forget the idea of acupuncture and just talk about anatomy and physiology, an acupuncture point is an area of sensitivity and reactivity. It's sensitive to impact, it's reactive to stimulus. And so it's normally perineural, which means it's next to a nerve. So you traumatize the tissue next to a nerve and you get a stronger segmental and central response, which is why specificity is important. You know, targeting is important. The other thing is about acupuncture points is they do 2 things. One is they give you a target which is effective physiologically, but to do that you normally need to be perineural. So what they also do is they miss everything that's important. They miss the artery, the vein, and the nerve as well. So it's already been mapped out. So dynamic integrated needling, it's dynamic because it changes during treatment. It's dynamic because you can change things physically with it whilst you're treating. And it's dynamic because it will evolve over time with how you practice. It's integrative because it integrates all forms of acupuncture. It doesn't, I'm not interested in naming things. I'm just interested in physiology and reaction. So I'm not interested in what they're called. That's just semantics. It's integrated because it integrates with exercise and loading and manual therapy. And the goal is to increase those things, to increase independence. And it's integrated because we also look at things from a parasympathetic perspective, like sleep, recovery, digestion, mental health, and so on. And it's needling. So it's essentially a results-based, clinically reasoned, evidenced approach to any utilization of a needle for any problem. But it doesn't suffer from being, oh, the rules of acupuncture or the rules of dry needling. Its rules are anatomy and physiology, and that's it. So that's what dynamic integrated needling is.
Excellent. That was great. Very great answer, that. You clarified it for me anyway.
Yeah, they can reach out to me if they want more, because that's what I teach. That's my style. That's my approach.
Okay, Fab, great. So the next question is, why is it important to explore the 3-dimensional structure of body parts? I'm guessing compared to more like the surface anatomy, but I guess you did cover that slightly with regards to the effectiveness side of things.
I mean, here's the thing, like if you want to hit a target, right? So I'll give you an example. And I don't know if the person in question is listening, but I'll direct them to this. The weekend I was teaching a course, one of the guys on the course, we went slightly off track and he asked me a question about his partner who had got a certain hip problem. And I suggested a technique, and he went away and he did it. He came back to me the next day, said, yeah, it was improved to some degree. It relieved the symptoms. They came back later on. And my response was, okay, well, we targeted a specific structure and it was beneficial. And I said, okay, well, on that basis, I'm going to show you how to be even more specific. Now, to do that, we had to go to an advanced technique. And I'm saying there's no such thing as advanced, but there is when it comes to anatomy, because if you're going to hit a target that's very, very deep in the body, and this is why the concept of 3-dimensional anatomy comes in and not just surface marking, because if you want to hit a sublayer, so I talk about 5 layers of tissue, but when you hit layer 4, okay, so if you want to needle me in the superior medial angle of my scapula, which is just up here, in that space, if you were going to needle down, and from the skin to my lungs on me in the first intercostal space is 17 millimeters. measured it with ultrasound scanner. And so in that space, you're going to go through skin, adipose tissue, connective tissue, and muscle, layer 4. But when you hit layer 4, 4A is trapezius, 4B is levator scap, 4C is serratus posterior superior, 4D is iliocostalis thoracis, 4E is external intercostal, and 4F is the internal intercostal. So that's 6 muscles you're going through. So understanding where your target is, where you need to go and where you need to stop is important. So going back to the guy who came on the course, I demonstrated how to find a structure that is pretty deep in the body, and it's very specific, and you have to map it from bone, not muscle, because one of the things I say all the time is, if you want to find muscle, stop palpating muscle, palpate bone, because soft tissue is going to distract you all the time. You know, it's something you do with ultrasound, you get lost, go back to the bone. Palpation, you get lost, go back to the bone. It's always a constant. So I demonstrated how to find this target, and I said that, you know, what you need to do, if that's the problem, you need to hit that target. If it takes it away, that's the problem. It's diagnostic. If it doesn't, then it's either not the problem and you're not in the right place. So being in the right place enhances your diagnosis, because it's one of the variables that's going to help you decide. So then he went away. We went through this. He went away. He needled her, messaged me back, said complete game changer. She's massively changed. It's like she's a new person, because all it was a myofascial problem. It wasn't pathoanatomical. It diagnosed that it wasn't pathoanatomical, the needle did. The needle diagnosed that that was the right place to be, and therefore, you know, you can load it and exercise and so on, because you're not dealing with a pathological problem. That's why understanding 3-dimensional anatomy is important. The other thing is as well, doing that and not hitting the bowel as well.
Yes,
so that's why it's important as well, because it's not just about what you hit, it's about what you miss. And this is what people need to understand. You're going to put needles in people. I see this all the time with piriformis. So we'll put needles in a piston in and so on. Got to understand that the other side of piriformis is the pelvic cavity, you know. So it's understanding where you are. It's not just your target, it's your collateral risk you need to understand to enhance the outcome. So that's why 3-dimensional, it's always important.
Yes, absolutely. Great. So just a couple more questions. Has Jonathan developed any dynamic tests under ultrasound that you might not read about in textbook?
So I do dynamic assessment with the needle, and I can use the ultrasound to see where I am when I'm doing that. One of the problems, and I suppose one of the contradictions with this, is when we can see the pathology with the ultrasound, it's not so important to use the needle for diagnosis in that tissue. So let's say again we have a tendinopathy at the elbow. The ultrasound could show us the pathology in ECRB, but what it won't show us is what's happening to the loading from that muscle. It can show us the subsequent loaded structure, which is the connective tissue, but it's not going to show us trigger points or so on in the muscle. Or same with the back. The needle is useful for identifying the tightness in those structures. So I do have diagnostic techniques for the needle, but the issue is if you use it with the ultrasound, you won't see anything pathoanatomical with that, and you won't see the tightness with the ultrasound. So they can be used within treatment, but there isn't a specific test where they both combine to show you the same thing. What the ultrasound shows you is which muscle you're in, and the needle will tell you if that's the one that's problematic because of the loading nature on the needle when you hit it, and the quality and the texture of the needle. So if I'm needling deep into the spine, you know, people come to me with back pain. I treat a lot of back pain, come to me with back pain, and I do challenge ideas about non-specific, because someone will come and we'll needle down to something like multifidus, and that'll make a massive difference. It can be an absolute game changer the way someone moves. But to get to multifidus, you have to go really deep in a lot of people. Sometimes, you know, 40, 50, 60, 70 mil in somebody's lumbar spine to get to where you need to be to affect that change. And the ultrasound can be useful for looking at which muscle you're in, but it's not great for showing you problems there. So yes, it can be used in conjunction, but perhaps not how you think. The needle gives you the answer. Again, I do teach that on some of my more advanced courses. So if anybody wants to learn more about that, reach out to me, and I can show you how to do that with necks and backs and things like that particularly. The ultrasound is great for peripheral joints anyway, but So I use it in conjunction, but not how you think. I can't see both things at the same time. I can see the muscle and I can feel the difference, but I can't see the difference.
Yeah, excellent. Okay, so just a couple of questions, sort of more on ultrasound. So is the needle vision software on ultrasounds recommended? Which again, I guess I can comment on that one, but do you have
comment on that from a technical perspective?
Yes, obviously with the ultrasound machines, yeah, there is an option of softwares that they come with a needle vision. So it's definitely a software that helps aid sort of, you know, with regards to the needle vision. However, the feedback that we have is that it is not a necessity. So it's not a necessity with regards to that, and clinicians can, you know, efficiently and effectively treat still without the needle vision software. So again, I think it's just down to sort of individual preference. The only difference is with the software is that needle vision softwares with ultrasound, you can change angles quite swiftly and sort of rotate maybe more so than just sort of the general settings that come through. So is it something that you use, John, at all?
Yeah, yeah. Well, when I bought the when I bought my equipment, I did request that. Another useful thing, a couple of things about that. You know, if you're going to invest in a system, the best investment you can make, buy the best machine you can afford, because it will give you the best imaging. Speak to, I actually got mine from PhysiQuip. So speak to the guys there, because they will go out of their way to help you with things. And I've actually, funnily enough, I've actually referred colleagues to PhysiQuip, and they hadn't got the machine that the colleague wanted, and they really helped them out with stuff and directed them to somebody else as well who had got that machine. So you know, they're pretty generous with their knowledge and support. And I also spoke with Chris Myers from Smog, and I've not actually done any work with them as well, and he was very generous with his time and with his knowledge, and guided me towards what to get with that. So a couple of things I would say about your investments with ultrasound. If you're thinking of bringing it into the clinic, it's great, you know, it's a game changer. But what I would say is, when you're costing this out going forward, cost out your training as well. And not only buy the best machine, but one of the best investments you're going to have is your education, because that's how you're going to get the best out of your machine. And if you see some of the cheaper machines, if you're really good, you can get great stuff out of a cheaper machine. If you're not great, you need the best machine you can get. What I would say is invest in both components and have that as your overall budget. And I would speak to the guys at PhysiQuip about the physical equipment, speak to the guys at Smog. And then before you spend any money on the actual equipment, you know, speak to the guys at Smog about what to get and how to think about your training, and then budget it all out and then go for it. Because I think you'll get the best out of it if you do that. I know guys who bought machines, and I was chatting to someone today who bought a machine years ago, and it's just sat there. You know, they thought they'd got a good deal because I think they bought it for $5,000 or something secondhand, but they've never used it. So they didn't save 10 grand, they wasted 5.
Yeah, exactly that.
They just they just bought one. They didn't speak to the guys at the company, they didn't speak to the trainers, they didn't speak to guys who've got 10, 20 years in the game, you know, and really know what they're talking about. So check out the Smug videos on YouTube. They talk about some of the machines as well.
Yeah, absolutely. It's about investing in that pathway, isn't it?
I think as well, check out PhysiQuip's Academy as well for some of the training on there, and you know, get as much information as you can before you spend your money. And then what happens, it will be a fantastic investment and you'll enjoy it. It won't be a frustration, and your accountant will be happy as well.
Good tip. Okay, so lastly then, got a question. Do you use needle guides with the ultrasound? So I think what we're referring to there is the attachment that you can put onto ultrasound transducers to help guide the needle in. I'm guessing that's something that...
No, so here's a funny thing. So I teach cadaveric anatomy. I teach palpation, and I've grown into anatomy over the years and years and years. So my anatomy is pretty good because I'm teaching it. And one of the things that I say to clinicians, and this is where teaching anatomy has become more and more a thing of mine over the years, is when I'm teaching an experienced clinician and they put a needle in, and I'm telling them they've got the target is, you know, XYZ or whatever, this place in this muscle, and they've got to put a needle in. A classic example is I'll demonstrate on a cadaver where piriformis is. So cadaver will have the skin on. And if you've ever palpated a cadaver, you'll realize you can't palpate anything on a cadaver. It's pointless. But I'll palpate the bone. I'll map the geometry of the pelvis. And I'll talk about that on a lot of my courses. I'll talk about the geometry of anatomy, how you can map things. So I map the geometry of the pelvis, and then I line the needle up, I insert it, and I put it into piriformis, and then I'll peel the layers back, and you can see where it is. And everyone's really surprised at how up it is, you know, how Keflad it is. Everyone thinks it's more caudal, but you have to understand where it attaches and the 3 dimensions of anatomy, you know, because you see in the textbook, it doesn't look like that on a person. And where I'm going with this is that one of the things I realize when people needle is I'm asking them to put a needle in a structure. So essentially they're putting a flag in the ground and telling me, that's where I think it is. There's your flag. You've marked it. And then I'll demonstrate that that's not where it is. And so over the years, my anatomy has become honed to be able to identify those things, not for anatomy's sake, but for teaching other things. So for me, I don't, but I can understand why people do. Just because it's a habit of mine to be able to map stuff, and I'm having to do it blind all the time by palpation. So yeah, but I can understand why people would.
Yeah. Okay, great. Well, I think that's sort of towards the end of the pre-submitted questions. I think just a live question about, again, any courses in Somerset or around that area, John.
Somerset. I am going to be in Dorset, I think it is, Shaftesbury in Dorset, in the summer, teaching a foundation course, which is, it's a basic 6-day Western Medical Acupuncture Foundation course. That is through the AACP. That's on their website. I'm where else am I going to be? I'm going to be in Cardiff. I know that's not that close, but it's closer than I am now. I'm going to be in Cardiff in the next couple of months with with Cardiff Blues, I think. And we're doing some stuff in rugby, and we'll do like a 1-day thing, and we might look at some of the needle diagnosis with that. I often do that with sports clubs and so on, because it's really quick and easy to change things in the back and so on. But what I would say to guys is I've got a new website coming soon, but if you reach out to me on social media and ask me directly and tell me where you are and tell me what sort of course you want, I can tell you where I am. In the next few weeks, once my website goes up, you'll be able to book on there and look at things. I'm always happy to go anywhere in the world and talk to anyone about anything. Just need to reach out to me. And if there isn't a course there already, we can look at how we set something up, and always good to go and talk to colleagues about things and try and entertain an idea along the way.
Yes, absolutely. And I think so the your Twitter as well, the Hobbs Masters Needling series, I keep an eye on that. There's always updates on there, is there, with courses and things like that? Or?
Yeah, so I've got Instagram, LinkedIn and YouTube. I haven't got Twitter. But I've got the problem is if I went on Twitter, I'll be there all week just chatting. So yeah, I'm on LinkedIn under Jonathan Hobbs. I'm on Instagram and YouTube under Hobbs Acupuncture. I'm on LinkedIn and Instagram pretty much every day, just posting courses and whatever. So if people want to reach out to me on there, you can get me on LinkedIn. If you want me to come and teach for your organisation, so I teach for lots of private courses as well that you don't see advertised. Teaching for the Army in a few weeks in Scotland, with Institute of Sport in a couple of months as well, like I said, with England before the World Cup, like Prem clubs and stuff like that. Also in the States, you know, with NFL and so on. So I'll go anywhere and talk to anyone about anything. Reach out to me if you can't see it anywhere, and we'll hopefully we'll do something and catch up on the road somewhere.
Yeah, absolutely. So there's lots of platforms. Oops, I just threw my pen. To keep posted on, like I say, where you're at and your course is at, and like I say, we always like to hear all about your jet setting as well. Which sounds
I've just in a message somebody sent, somebody's asked about level 4 or 5 clinical therapists. So I've got a foundation course at Swan, physio and rehabilitation, which is in Stoke-on-Trent, and that one's in May and June. And that is a 6-day foundation where we'll be covering the whole body, Western medical, do some trigger point dry needling, we'll do some electro, acupuncture, and we'll cover these concepts, and we'll cover a lot of clinical reasoning. That's going to be there. Check that out on my social media or on the Swan Physio website. There we go.
Excellent. Lovely. Well, thank you very much. And thank you everyone for joining us this evening. I hope you enjoyed the session. Thank you again, John, for your time and obviously your expertise. Yeah, it's been a pleasure having you in the PhysiQuip Academy platform. So following this, you will receive a survey along with the link to the webinar recording. So we will appreciate any feedback that you do have and suggestions for future webinars. You can visit the PhysiQuip Academy site, which there's a link there just on the slide, where you can find all our past webinars and other educational resources as well. So with that, thank you again, John, and otherwise I'll say thank you and good night for the rest of the evening.
Thank you. Thanks a lot, everybody. And I really appreciate it. And hopefully catch up with you again somewhere soon. Bye-bye.